So the diagnosis of nontuberculous mycobacterial lung disease really depends on three different things. Of course, the first is that you have a patient with symptoms compatible with that disease, and you have radiological imaging showing signs of that disease, and they come in different manifestations, but very well recognizable manifestations. And then microbiology really is the closing argument. You find the causative bacteria in these patients' excreta, so sputa. And that's when you know the symptoms and the radiology are caused by the bacteria that I now culture. Well, of course, the first step is that you culture mycobacteria from patients' sputum or bronchoalveolar lavage. And then what is adamant is that the mycobacteria are correctly identified to species level, because not all mycobacteria are equally capable of causing disease in the lungs. So having the name is really crucial information to the clinician, because it can already tell you, do I have to take this very serious, or is this probably just an occasionally present mycobacterium from the environment that doesn't cause any harm? Identification, therefore, is paramount important. And that requires often looking at the DNA of the bacterium, either by sequencing approaches or like line probe assays. There are different techniques, but DNA-based techniques are probably the best for now. And we are slowly working on other techniques in the laboratory, including MALDI-TOF. But it is, for now, mostly genetic testing that tells you which bacterium it is, and that tells you whether this is likely to be a causative agent of disease or not. Well, as I said, there's already communication between the microbiologist and the pulmonologist, about, oh, this is what we found and this might or might not be pathogenic. But really, diagnosis and treatment of NTM lung disease should be a multidisciplinary team activity. And now microbiology is in the team. Of course, the pulmonologists are in the lead, but you need a radiologist, to make sense out of what the radiological imaging shows, also what it shows over time. You need a hospital pharmacist to help you if you start treatment with multiple antibiotics. Then they might interact with other medication this patient is taking for comorbid conditions. So having a pharmacist alarm you like, oh, these drug combinations might be harmful to the patient is, I think, of crucial importance as well. That is the million-dollar question, and I think for now it really comes down to two very separate issues. The first is, of course, recognizing that this is a disease, it's out there, and pulmonologists likely encounter patients with this disease on a regular basis. So it comes down to recognizing this disease in patients, even in its very early stages, thinking about the disease and actively trying to make a diagnosis, which might involve doing very difficult things like bronchoalveolar lavages in patients who have very little symptoms. It might mean having to do a high-resolution CT scan in patients. But so the suspicion of the clinician, this could be NTM pulmonary disease, I think is the most important. Early recognition. And then the other big thing we need is better treatment regimens. So the currently available and currently recommended treatment regimens consist of multiple antibiotics over the course of 1.5 to 2 years. And yet their outcomes are really poor. So even the currently recommended treatment regimens only cure 50 to 70% of the patients, depending on which bacterium causes disease and what type of disease they have. So we need new drugs, better use of the currently available drugs, and smarter and shorter regimens. Well, the best news in a long time is that literally 3 days ago, the results of the CONVERT trial appeared as an online publication showing that in patients who have failed on previous treatment, retreating them with a guideline-based therapy plus this amikacin liposomal inhalation solution really increases their chance of a culture conversion, suggesting a long-term effect. And that is, for now, I think, one of the biggest new things that can really improve what we're doing. So the other thing that has been investigated is a new anti-TB drug called bedaquiline, and some retrospective data of treatment of individual patients has now been presented. Its outcomes, sadly, were not very good, but I think if we make smarter use of that drug, for example by combining it with clofazimine, which has shown encouraging results in mouse models and other preclinical models, might boost the efficacy of that drug as well, but that has yet to go into real clinical development.